Hello, welcome to the EKG Guy and welcome to the EKG of the Week. I hope you're having a great week and I'm glad you could join us. This week's case is an 80-year-old male with a history of alcohol abuse and phantom limb pain that presents to the ICU following a drug overdose. His presenting EKG is shown here. Now before we get started, let's review the approach we've been using to interpret EKGs. So notice that we have the patient's clinical presentation in the EKG below it. On the right side of the screen, we have a list that we'll go through before making our final interpretation. First, there's the regularity of the rhythm. That is, are we dealing with a regular or irregular rhythm? And if it's irregular, is it regularly irregular or irregularly irregular? Next, we have the heart rate, in which we simply want to determine the rate of the rhythm. Then we'll look at the rhythm origin. That is, where is the rhythm actually originating from within the heart? Then we'll have to determine the ventricular or QRS axis, which could help us with our differential diagnosis. And then there's the atrial, atrioventricular, and intraventricular conduction, looking at if conduction is normal or abnormal in any area within the heart. Then we have the waveforms, which would include all the waves, segments, and intervals. And lastly, anything else, meaning is there anything else that we missed or still need to mention, such as abnormal R wave progression or transitional zone in the preaurial leads. After that, we'll use all this information we've gathered to make a final interpretation of the EKG. Now I want you to pause the video and take a few minutes to go through it yourself. When you're ready, start the video and we'll go through it together. Alright, so our 80-year-old male has a history of alcohol abuse and phantom limb pain, and he presents to the ICU following a drug overdose in this EKG. So let's walk through it. So first, what is the regularity of this rhythm? Well, on first impression of the EKG, you probably notice that the rhythm appears irregular. However, there is some regularity to it. Therefore, we would call this a regularly irregular rhythm. Okay, so we'll write that here. This is a regularly irregular rhythm. Okay. And how do we find that out? Okay, so one of the main things we look at when we look at the regularity of the rhythm is to use the R to R interval. Okay, it's the easiest often to make out, so we'll use that here. So let's look down here at V5. Okay, so here's one R wave and here's the next one. Okay, so this is considered the R to R interval. Now what we want to do for a regular rhythm is to have these R to R intervals to be consistent throughout. Okay, so if you notice here, notice that this R to R interval, okay, to this R wave, is much shorter in duration, okay? And then if we look at the one that follows it, from this R wave to the next, it seems much longer than that in black, all right? And then we have an R to R interval, and notice that how it's constantly changing, okay, from longer to shorter, okay, with the longer ones being in red, and then the black ones being a shorter duration. All right, so you'll go from a longer to a shorter and longer to shorter, and you see that constantly throughout this EKG rhythm. Okay, so because we have a varying in the R to R interval, we call that an irregular rhythm, but then there's that regularity to it, so we call this a regularly irregular rhythm. So what did you get for the heart rate? Well, because we have an irregular rhythm, we can get an estimate of the heart rate by adding up the complexes going across the EKG and then multiplying it by 6. Now, because the EKG represents 10 seconds, we can do this. So let's try it. So remember, from beginning to end of the standard EKG represents 10 seconds. Now, if you multiply 10 seconds by 6, that gives you 60 seconds, which is 1 minute. Meaning if we count the complexes going across, multiply that by 6, we can get the beats per minute. So we'll do that now. So we have 1, 2, 3, 4, 5, 6, 7, 8. Okay, so what you do here is 8 times 6 is 48 beats per minute. That's our estimate. Okay, the actual rate that they got on the machine was 50. Okay, so pretty close to the actual rate. Now let's look at the underlying rhythm here. Okay, where is it originating from? Well, in this case, we notice that we have narrow QRS complexes, so it must be supraventricular in origin, that is originating from above the ventricles. We can also make out clear defined P waves in each lead. However, their morphology of these P waves is not exactly the same in each. Okay, so do we have sinus rhythm present? So let's take a look at that. Okay, now when we talk about sinus rhythm, that means it's coming from the sinus node. Okay, and you'll notice here that we have some P waves that have a varying morphology. Okay, so if you look at this P wave, it has the same morphology as this. Okay, however, those in between them have a slightly different morphology. Okay, it's a little difficult to see here, but if you trust me, they are slightly different. Okay, and those in red have quite a similar morphology. Okay. So because of that, we may actually have sinus rhythm, all right, but we may also have an atrial rhythm involved here too, okay? So remember, with sinus rhythm, what we're expecting to see are upright P waves, okay, in leads 1, 2, AVF, all right, as well as those lateral leads, V4 through V6, inverted P waves in AVR, okay? And we want to have one P wave before each QRS complex. And remember, the P wave morphology should be the same in each of those sinus beats, okay? So those in red here are what we consider our sinus beats, and we'll see why that's the case, okay? So if you look here, notice we have an upright P wave, all right? A little difficult to make it out in here. Remember, the ones in red are the ones we're talking about, okay? So again, hard to make out our P wave here. But you can see in these lateral leads, these are upright P waves, okay? So we actually do have sinus rhythm here, okay? And then we have beats that are coming earlier than expected with a different P wave morphology, and that's what we call premature atrial contractions, okay? So in this case, we have a sinus rhythm. Okay, so the rhythm's originating from the sinus node. However, it's interspersed with these premature atrial contractions, or these PACs. Okay, and remember those PACs, notice them in green, are coming every other beat. Okay, and when you have these PACs coming with every other beat, we call that a bigeminal pattern. Okay, so this is called bigeminy. All right, so sinus rhythm, okay, with a bigeminal pattern. Hopefully that makes sense. Now let's look at the ventricular or QRS axis. Now you should have gotten a normal QRS axis. The actual value here was positive 12 degrees. So how do we find the ventricular axis? Okay, so just to review, this is 0 degrees, this is positive 90 degrees, plus or minus 180 degrees, okay, and negative 90 degrees. And what we do here is we have to place our leads. So this is the positive end of lead 1. Okay, this is AVF down here, it's positive end. All right, and remember that normal axis lies between negative 30 degrees and about positive 105 degrees. Okay, so within that region, this over here is considered normal axis. Anything over in this region is considered a right axis shift or right axis deviation. This would be left axis deviation and extreme axis deviation. Okay, so what we're looking for first is we'll take a look at lead 1 and AVF. So notice that lead 1 here has this positive upright QRS complex. Remember, we're looking at the ventricular axis, so we're going to look at the QRS complexes, okay? So notice it's going towards lead 1, okay, in this direction. And then if we look at AVF, here's our QRS complexes. Notice that they're mostly upright, going towards the positive end of AVF. So that puts us in somewhere in this region. So we have a normal ventricular axis, and the actual axis here was positive 12 degrees, okay, which would come out to about this area. This would be positive 12 degrees. Okay, so a normal ventricular or QRS axis. Now, how about atrial conduction? Okay, well, typically we look at leads 2 and V1 for P wave or atrial abnormalities, as they appear to be the most evident in those leads. The P waves are present in both leads here, but are more evident and easier to make out in lead V1. The P wave amplitude and duration appears within normal limits. Now, normal P wave duration is typically defined as less than 120 milliseconds, or 3 small boxes. Now, if the P wave duration is prolonged, then we start thinking about more left atrial abnormalities, okay? And why is that? Well, it's because the terminal portion of the P wave represents left atrial depolarization, while the initial portion of the P wave represents right atrial depolarization. Anyways, it's normal here, so we don't have to worry about that, okay? So remember, if you look at V1, where it's so V1 down here as one of our rhythm strips, notice it's easier to make out those P waves that we've circled already, okay? And none of them have an increase in amplitude, okay? We see no deep biphasic terminal portion of any of these P waves, all right? And their duration is normal. So we have normal atrial conduction. What about AV, or atrioventricular conduction? Well, in this case, we're looking for any conduction delays as the impulse travels between the atria and ventricles. Because the majority of the PR interval represents the AV nodal conduction, we look there. The normal PR interval in adults, which we're dealing with here, okay, this 80-year-old gentleman, we typically have a duration between 120 and 200 milliseconds, which is about 3 to 5 small boxes. Here, the PR interval is within normal limits. It was actually measured at 182 milliseconds. milliseconds, which is more of an average in the setting of these premature atrial contractions. Now, because these PACs originate from an area outside the sinus node, the PR interval will vary. If the PAC originates from close to the sinus node, the PR interval may be nearly identical, whereas if it originated from near the AV node, it may be shorter, okay? If we're somewhere within the left atrium, okay, it may be longer. So for our purposes, the PR interval in each beat here is within normal limits, okay? So we have a normal AV conduction, okay? So remember, when we look at this, imagine this is our heart, our right atrium, right ventricle, and left ventricle. When we talk about PACs, okay, so we have some of these beats in red originating from the sinus node, okay, and they're going to our AV node right here. All right, and what we also have going on here are these early beats from some ectopic foci within the atria, okay, so imagine one originating from maybe this place here, okay? So it will travel towards the AV node, and because the distance may be similar to that of the sinus node, the PR interval may also be the same. However, if you had one originating from with here, it may actually be longer than our normal sinus PR interval, okay? Whereas if it's originating pretty close to the AV node, it may be shorter, okay? So that's just something to keep in mind. So we had normal PR intervals here. The average was about 182 milliseconds, which is below that upper limit of 200 milliseconds. Okay, next we have the intraventricular or IV conduction. Here we look at the duration of the QRS complexes. Normal QRS duration is often between 70 and 110 milliseconds, or about 2 to 3 of those small boxes. The main thing here we're looking for with intraventricular conduction is whether or not the QRS interval is prolonged. We can see narrow QRS complexes that appear within normal limits. In fact, the QRS duration here is measured at 94 milliseconds, so that helps to confirm to us that IV conduction is normal, okay? And another thing to note is that the QRS duration will be the same for each beat here, because everything below the AV node occurs as it normally would with the sinus beat, okay? So even though we have these premature atrial contractions, okay, whether it's originating from here or here or here, okay, all of them then come to our AV node, and everything below into our ventricles is the same. Okay, so conduction down here in the ventricles is the same, so our QRS duration, our QRS complexes should be the same. Okay, so in this case, we can say that we have normal intraventricular conduction, okay, and the duration was 94 milliseconds. Now, how about the waveforms? Well, the P waves we said were normal, albeit had a differing morphology with every other beat, okay? In general, there were no significant P wave prolongation or increase in amplitude in leads 2 or V1. No abnormal Q waves are present. The T waves are present, asymmetric, and appear normal. T wave amplitude is generally the greatest in leads V2 and V3. The PR segment is not significantly depressed or elevated anywhere. The PR and QRS intervals we said were within normal limits. The QRS amplitude, okay, it appears normal here, so there's no evidence of hypertrophy. The ST segment does not appear significantly elevated or depressed anywhere. Now note that there are some areas of discordance of the T waves in the main QRS vectors in leads 1 and AVL, and these appear to be more nonspecific changes. So what we're talking about here is, if we just erase some of this, okay, and 1 and AVL, so here's a QRS complex, okay, and notice you have this T wave here, so the QRS complex is going up, and normally the T wave should go in the same direction, but you have it almost flat or somewhat inverted, this T wave here, okay, and the same thing is in AVL, so here's an upright QRS complex, and it seems like we have that inverted T wave there, okay, same thing here. So because we want to have this concordance, okay, unless you have hypertrophy or a bundle branch block, okay, in which case it would be normal. And because it doesn't seem like it's representing any pathological features, we call these more non-specific ST wave abnormalities, okay. So we can write that here. So non-specific ST wave abnormalities, okay. So that's one thing to note. All right, now lastly with the waveforms, the QT interval is within normal limits. The QTC interval here was 404 milliseconds. Remember, in men, we consider the upper limit of that QTC interval to be 440 milliseconds. Okay, in women, it's a little longer at 460 milliseconds. So overall, there are no major waveform abnormalities here except for the varying P wave morphologies that we noted and the non-specific ST wave abnormalities. Okay, so we can also put that the varying P wave morphologies, okay, in that bigeminal pattern. All right, so is there anything else here we're missing? Well, how about the R wave progression in the precordial leads? Normally, the R wave amplitude should progressively increase from leads V1 to V5, okay? In this case, it seems like there are stronger anterior forces and weaker septal forces, evident by the similar amplitude of the R waves in V1 and V2, okay? So here's V1, and this is V2. These are our small R waves, okay? Very similar in amplitude compared to those in each lead. And then when we get to V3 and V4, more of those anterior forces, notice how the R wave amplitude starts to increase much more. So stronger anterior forces compared to those septal forces, okay? So that's what we were looking at, okay? Normally the R wave amplitude should increase from V1 to V5, okay? So that's one thing to note here. Now the transitional zone in the precordial leads appears to occur somewhere between leads V3 and V4. The transitional zone is simply the precordial lead area where the QRS transitions from being mostly negative to mostly positive, with the actual transitional area being where the QRS complex is isoelectric. Normally the transition occurs between leads V3 and V4. If it occurs earlier than V3, we call this a counterclockwise rotation or early transition. And if it occurs after lead V4, then we call this a clockwise rotation or late transition. Now, because the transition occurs here, in this case between V3 and V4, we would consider this a normal transition, okay? So what do we mean by this? So just to erase this, you can see. All right, so obviously you can tell in V1 and V2, these are mostly negative, okay? And then we get to V3 and V4, okay? So look at V5 and V6. You can see these are mostly positive, okay? And if you were to measure these out in V3 and V4, this would come out to be still mostly negative, but when you get to V4, it becomes mostly positive. So going from that transitional zone occurs somewhere between V3 and V4, okay? In that case, we call this a normal transitional zone, okay? So we'll just put normal transition. Now, one thing to keep in mind with R wave progression and the transitional zone is that they're highly dependent on lead placement, okay? Now, I just want to say a few final words on premature atrial contractions before we end here. Now, these occur when pacemakers within the atria fire at a faster rate than the sinus node. They reset the sinus node, resulting in what we call a non-compensatory pause. They occur earlier than expected and lead to an irregular rhythm with P-wave morphologies and sometimes PR intervals that differ from the sinus P waves and sinus PR intervals. Intraventricular conduction is similar to the underlying rhythm, okay? Then that means we should see no change in the QRS complexes, as we mentioned earlier. Anyway, so what's our final interpretation? Well, we have a regularly irregular rhythm with a rate of about 50 beats per minute. We noted sinus beats interspersed with premature atrial contractions in a bigeminal pattern, as well as nonspecific ST T-wave abnormalities. Therefore, this is sinus bradycardia with premature atrial complexes in a pattern of bigeminy with nonspecific ST T-wave abnormalities. And when we look back at a prior EKG, the only changes is that now we have evidence of these PACs and a decreased ventricular rate by 39 beats per minute, okay? So let's write our final interpretation here. Erase this so we have some room. So our final interpretation, we said, was this sinus bradycardia. Okay, the rate was 50 beats per minute. We had some sinus beats. We also had these premature atrial contractions, okay, with a bigeminal pattern, okay, because they were occurring every other beat, okay? Remember, these premature atrial contractions are occurring earlier than expected and having and originating from the atrium. And then we also mentioned some non-specific ST T-wave abnormalities, okay, that we notice in those lateral leads 1 and AVL. And then when we compare it to a previous EKG, okay, so versus the previous EKG, what we see now are new PACs, and then we also mentioned that the rate has now decreased, so the ventricular rate has decreased by 39 beats per minute. Okay, so the rate here was 50. Okay, so in conclusion, our 80-year-old male with a history of alcohol abuse and phantom limb pain that presents to the ICU following a drug overdose has an EKG showing sinus bradycardia, premature atrial contractions in a bigeminy pattern, as well as nonspecific ST T-wave abnormalities. Well, that's the end of this week's EKG of the week. I hope you learned something. Please don't forget to like this video and leave a comment below if you like what we're doing. In fact, many of you have asked how you can help us out. Really, the best way would be to simply subscribe and share this resource with your friends. You get free access to more than 300 videos. There's also a community of over 150,000 of us like-minded individuals on Facebook, so stop over and join the EKG Guys Facebook community. If you need a crash course on EKGs, we launched our new EKG course. Check the link below if you're interested. The original cost is around $150, and I believe I made it less than $20 for a limited time. I may be biased, but after reading nearly every EKG textbook on the market, I think this is by far the best EKG series to take you from the beginner level to a physician level. I've even included our pediatric lectures. Anyways, check it out for yourself. I think you'll really enjoy it, and a number of medical schools and hospitals are beginning to use it. If you are a part of an institution, please contact us because we're giving a limited number of schools and hospitals free access to provide feedback and improve our course. And in that case, you can get the course for free. So leave a comment below and get in touch with us. And of course, check out our brand new website, ekg.md, the premier EKG resource for medical professionals, where you can find more lessons and practice. That is www.ekg.md. Last but certainly not least, your feedback is incredibly helpful, and your kind words are always an encouragement on those long days. So let us know how we're doing. Thank you again for your support. It is truly appreciated. We're the largest, fastest growing EKG resource in the world.